Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. Hi, all you BTK listeners. It's Scott here, and I want to talk a little bit about our BTK colorectal surgery oral board audio review. With upwards of 50 plus high-yield scenarios designed for colorectal surgeons by colorectal surgeons. These scenarios are 5 to 7 minutes long. They got a variety of tactics and styles. We also have a high-yield commentary to each scenario that includes tips and tricks that'll help you dominate the most challenging of scenarios. In addition to practical, easy ways to think through, easy to understand teaching style that covers most confusing, most interesting, and the most basic of topics that we all face as colorectal surgeons. So we are highly confident that you will find this unique dual format approach a highly effective way to prepare for your test. And now listen, best of all, every course subscription now comes with access to our revolutionary oral board simulator. You can practice out loud your decision-making under pressure to identify and fix your knowledge gaps before you face the real examiners. Check it out at behindtheknife.org.
Hi, everyone, and welcome to Behind the Knife. I'm Elissa Dabaghi, a general surgery resident at Cleveland Clinic.
And I'm Jared Hendren, another general surgery resident at Cleveland Clinic, and we're joined by members of our colorectal surgery team.
Hi there, I'm David Rosen, the Vice Chair of the Department of Colon and Rectal Surgery and the Section Head of the Division of Colorectal Surgery at Cleveland Clinic Fairview Hospital.
And I am Ajaratu Keshinro, one of the Assistant Professor in the Department of Colorectal Surgery at Fairview.
And I'm Joseph Trunzo. I'm the Program Director for the General Surgery Residency Program.
I'm also a colorectal surgeon. We'll keep you as part of our team.
And I'm a colorectal surgeon.
Yeah, congrats to Dr. Trunzo. He was just named the General Surgery Program Director for us. We're very excited. So let's go ahead and get into our discussion. It's well known that a significant portion of patients with Crohn's disease will require surgery, typically an ileocolic resection. And while surgery can be highly effective for symptom control, recurrence is the rule rather than the exception. And depending on the definition, endoscopic recurrence can occur in 50 to 60% of patients within 1 year, and clinical recurrence can occur in up to 40 to 50% of patients within 5 years. In an effort to reduce recurrence, surgeons have focused on the configuration of the anastomosis, the development of novel anastomotic techniques, and the role of the mesentery itself. Today, we're going to discuss 3 journal articles that reflect this evolution in thinking and discuss how they help shape the way we approach ileocolic resections and anastomoses in Crohn's disease. So our first paper focuses on the question, does anastomosis type matter at all? A while ago, McLeod et al. Published a multi-center RCT in the diseases of the colon and rectum in 2009, assessing endoscopic and symptomatic recurrence at 12 months for patients who had a stapled side-to-side anastomosis versus a hand-sewn end-to-end anastomosis. 139 total Crohn's patients were included in the efficacy analysis. 66 had a side-to-side and 73 had end-to-end anastomosis. And their study showed that endoscopic recurrence at 12 months was similar between groups, with 37.9% of side-to-side anastomosis patients versus 42.5% of end-to-end anastomosis patients experience recurrence. Similarly, there was no statistically significant difference in symptomatic recurrence, with 22.7% of side-to-side anastomosis patients versus 21.9% of end-to-end anastomosis patients experiencing symptomatic recurrence.
Great. Okay, so let's talk about how these results could apply to a patient in clinic. So you have a symptomatic 28-year-old man with ileocolic Crohn's disease. He has fibrostenotic disease and a short stricture, and he hasn't trialed any biologics yet. He's otherwise healthy, non-smoker, and he's undergoing ileocolic resection, So prior to the Crohn anastomosis, what anastomotic technique would y'all perform for this patient, and would this be patient-specific? And also, what is y'all's thoughts in general deciding on anastomosis you'll be creating for a patient with Crohn's?
So I think that to sort of set the stage, it's important to point out we're talking about this because this is such a problem. The disease and the biology of Crohn's disease is such a problem. And we're trying to figure out how do we help patients get their surgical resection and not have to have another one, because the more you keep taking and taking and taking, you will end up with short gut and have other complications. So I think it's important to point out that we don't know exactly what the best way to prevent that from happening is. So we're investigating and experimenting with new techniques. And so that, I think, is important to set the stage before we each kind of go around and talk about what is our personal preference and why.
So I'll say, just like with a lot of things in surgery, having more technique in your toolbox is probably going to be beneficial when you're managing a disorder like Crohn's disease. And then early in my career, it was very common that we would just simply do a side-to-side anastomosis because it's a wider connect. You can make a nice wide anastomosis as long as the small bowel and the colon were soft and healthy. I've evolved from that, and a lot of people have, I'm talking about stable anastomosis, to an end-to-side for a couple of reasons. One, with an end-to-side anastomosis, it's a little more simplistic to intubate the terminal ileum after an end-to-side ileocolic anastomosis from a gastroenterologist and sort of surveillance standpoint. And also, invariably, if they develop a stricture at that anastomosis, it's also a little more simplistic to dilate a stenotic stricture at a circular anastomosis as opposed to sort of an oblong angle from a side-to-side functional end-to-end anastomosis. So my routine on an elective ileocolic resection with otherwise healthy bowel would be an end-to-side, and that's my current preference.
And tell us real quick, how do you do that specifically when you're talking about end-to-side?
So typically, I'll use a circular end-to-end stapler, or EEA stapler, the anvil sewn into the small bowel. Through the proximal end of the colon, typically around the cecum, we'll insert that stapler, bring the pin out, the anti-mesenteric border of the proximal ascending colon. And once that's done, you create your end-to-side ileocolic anastomosis with your circular stapler. And then there's various ways you can deal with the cecum, whether you resect it and primarily close the stump, or you use a TA stapler to fire across the cecectomy portion of your colon.
Yeah, for me, I'm definitely a reflection of my training. So in residency, we tend to do end to side, and then fellowship, we did a lot of side to side. So, what I'm most comfortable with for a lot of the reason Dr. Trunzo just mentioned is doing an end to side. So I tend to use a 28 EA purple stapler to do my end to side, and most patients, honestly, I can't really think of any reason I'm not able to do that, and then I'll switch to a side to side. So I tend to do end to side nowadays. I'm more comfortable with that now.
I will add one other component to this. If the patient has been chronically obstructed at the site of the ileocolic disease, and they'll have edematous sort of proximal small bowel that is healthy and not part of their disease process, sometimes I would try to refrain from a staple. I worry about a staple anastomosis when the bowel is very edematous. And in that situation, I would do a hand sewn. And kind of going back to this study that you were talking about, end-to-end anastomosis, typically what I would do is actually do an isoperistaltic side to side, which endoscopically is fairly easy to get yourself navigated from the colon into the small bowel with an isoperistaltic anastomosis. And I can also create the width I'm looking for when I do it side to side, as opposed to end to end. You're sort of beholden to the end of the bowel.
Yeah, I think those are all great points. And my practice is pretty similar. The only thing I'll really add is that I think there's a lot of times, and Joe, you started to get into it just there, patient factors matter a lot with what you find intraoperatively. And I really try myself to avoid diverting loop ileostomies in Crohn's patients when possible for ileocolic resections. So for me, I'm either doing an anastomosis or an end ileostomy and letting things settle down to then come back another day for the anastomosis. Depending on the patient factors, how much creeping fat there is, right? Because if you only have a sliver of an anti-mesenteric end, sometimes sewing in that anvil for endoside is not easy. You're kind of coming through and you try to clean up some of the fat and it starts bleeding and shredding. So that might be a time that I would think about an isoperistaltic side to side, where you fire a linear stapler in the isoperistaltic fashion and then hand sew, close that gap. But I would say my standard is either an end to side, exactly the way Dr. Trunzo described, ileocolic anastomosis, or the Crohn-OS, which we'll talk about here shortly. But there's patient factors, and I used to think, like Dr. Trunzo mentioned, that having a wide open anastomosis, when I first started, I was doing a lot of anti-peristaltic side to sides, and we always thought that wide anastomosis maybe would help. But when you think about it, when the patient recurs, it's usually just proximal to the anastomosis where that kind of stricture and narrowing happens. So I think the width of the actual anastomosis itself might matter a little less than you used to think. And so typically I'll do an endoside with a 31 EEA anvil and versus a large Crohn-OS, and that's kind of my standing.
Yeah, great discussion, guys. So recently, a meta-analysis by Bignali et al. That was published in the International Journal of Colorectal Disease also showed no significant difference in endoscopic recurrence between stapled side-to-side and hand-sewn end-to-end anastomoses. But as mentioned, that you guys talked about, there are many other things to consider when you're choosing the type of anastomosis for Crohn's patients. And while we won't get into the details of the study, I do think it is interesting that Crohn-OS anastomosis showed a trend toward lower endoscopic recurrence in that group compared to the side-to-side group at 31.8% versus 39.8% respectively, when considering endoscopic follow-up between 6 to 12 months. But this conclusion in their study was limited due to variation in study design, definitions, and post-operative management. But this does set us up well for our next paper.
Great. So yeah, our second paper focuses on, this novel anastomotic techniques, and it's the Supreme CD trial published in Annals of Surgery in 2020. This was the first RCT comparing the Crohn-OS anastomosis to a conventional stapled side-to-side anastomosis in Crohn's disease patients that were undergoing ileocolic resection. So the Crohn-OS is an anti-mesenteric functional end-to-end hand-sewn anastomosis that places the anastomosis away from the diseased mesentery and reinforces it with a central supporting column. The primary endpoint was endoscopic recurrence, defined as Root-Geertz score of I2 or higher at 6 months. 79 patients were randomized, 36 to the Crohn-OS group and 43 to the conventional group. At 6 months, endoscopic recurrence occurred in 22% of the Crohn-OS group compared to 63% of the conventional group. At 24 months, clinical recurrence was 18% versus 30%, and surgical recurrence was 0% versus 4.6%. So there was no difference in post-op complications between the two groups as well.
Yeah, now let's talk about how these results could apply to a patient scenario. We have a 38-year-old woman with, let's say, 5-year history of ileocolic Crohn's disease, fibrostenotics, failed 2 biologic, now presenting for elective ileocolic resection. No prior abdominal surgery, preoperative imaging shows isolated terminal ileal disease with a short stricture, and she's asking you whether the type of anastomosis matters for her risk of recurrence. Based on the Supreme CD trial, how would you counsel her? And has this trial changed how you, has it changed your practice, essentially? I'll ask that.
So first thing I'll say is, and these patients sometimes are like this. They're very, very into what's going on. She actually is asking about what type of anastomosis would matter. But that does sometimes happen. And so, I think that this trial and the Crohn-OS anastomosis was very exciting, I think, for surgeons because so much is moving away to patients not needing us, right? All these biologics, they don't need us anymore as much for Crohn's disease. Rectal cancer management is going towards watch and wait. So here is something that we as surgeons can help contribute with the way we're constructing our anastomoses in these Crohn's patients. So I think it's very, very exciting. There is really good data. Pretty much all the data for the most part is European. And, this data shows that, that 22 versus 63% decrease in endoscopic recurrence is quite impressive. The problem, and with a lot of these European trials, the knock on them that people talk about is pre and even and especially post-operatively, the rate of biologic treatment of these patients was quite low. Half or even less than half of the patients were on biologics. And so there's a trials going on in the U.S. now that'll look at that and aim to have a higher rate of postoperative biologic treatment to help answer the question, is it truly the anastomosis itself? Or if they were on biologic treatment, would that negate any benefits made from the anastomosis? I will say that, the rationale of it makes sense. right? We've sort of shifted towards thinking that the mesentery is a large component of this disease process. And so you're getting the anastomosis away from the mesentery. Most of these trials, or most of the people, the way that people do this involves a mesenteric, extended mesenteric excision, which we'll talk about in the next paper as well. And so dealing with the mesentery, right, focusing on how we do the anastomosis and dealing with the mesentery, I think really adds benefit. It makes sense. Now, well, will it play out that biologics are supreme and it might not matter if they were patients on postoperative biologics? That remains to be seen. But there's no doubt that the Cone-OS has been shown to be beneficial in a patient like this.
I think, one of the things is talk about the technical considerations in it. Obviously, it's a more demanding technical proportion, so the surgeon himself has to have a better understanding of how to do the anastomosis in this way. We've all been pretty well taught on how to do hands-on anastomosis and stapled anastomosis, but the setup from this in three dimensions and how you kind of think about it, I think you take some time to kind of understand how you're going to do it. So when you're starting to bring this in as part of your practice, you just have to make sure that you have a good understanding of what you're trying to accomplish at the time of the operation. I mean, Dr. Rosen, when you started doing these more often, like what were some of those technical limitations that you ran into, or things that you're just like, I had to do to kind of set yourself up for success with it?
Yeah, just like any new technique that you adopt that you haven't necessarily done in your training, you're uncomfortable with, there's a lot of getting used to it. And part of it starts with observing people do it, whether it's watching on videos or having partners that do that you can go and observe and watch. And you can practice suturing, if you have access to, you can go out and buy some pig intestine or something, at the local market and sort of put things together. No, I'll be honest, I didn't do that, but it's an option. And, and then at some point you have to kind of know I think we all have, as surgeons, all have to, push ourselves to the next limit and do what's best for our patients. And so that was it. And at some point you kind of have to dive on in. There's no doubt that one of the big downsides of it is it takes longer. I'd say it adds about an hour to my operation doing it this way. It's a lot of suturing. There's new techniques coming out that haven't been studied like this in terms of how to do it in a stapled fashion, which I think would appeal to people a little bit more in terms of saving on some of that time. But whether those have the same benefits as the sutured Cone-OS anastomosis remains to be seen. It needs to be studied. But there's no doubt it adds time. There's no doubt, just like any new technique, you start off and you're going to be uncertain, like, oh, is that the right? Especially as you're turning corners as you come around on some of these anastomoses, is that the right amount of turn? Am I doing this the right way? Should I canal this stitch? Should I not? And those are the type of thing I think whenever you adopt something new, you have to rely on your basic foundational knowledge of hands-on anastomosis in your training and keep powering through to do new techniques to be better for our patients.
Yeah, I mean, I think at this point in time, based on the current data, I will still be doing NTOSIDEs. I would like to see a head-to-head comparison of NTOSIDE versus Cone-OS to really make sure that there is a clinical significance, because I do think that, endoscopic recurrence is one, but what is the significance of that? Are these patients requiring to be on biologics? Are they requiring surgery? So I would like to see some kind of substantial data regarding that for me to make a switch in my practice. And some of it is just based on my comfort level. I was not trained to do Cone-OS, so more reflective on that than anything. So,
okay. Our third discussion combines two papers that together ask a different question. Does what we do with the mesentery during resection affect recurrence? The first of these two papers is the Mesocoloric trial published in early 2025. It was an international multi-center RCT that randomized 116 patients undergoing primary ileocolic resection to either extensive mesenteric excision, which was defined as resection up to 1 centimeter from the root of the ileocolic artery and vein, or conventional limited mesenteric excision, where the mesentery was preserved within 3 centimeters of the bowel wall. The primary endpoint was surgical recurrence, with endoscopic recurrence as a secondary endpoint. And I think it's important to read this alongside the SPICY trial, which was published in the Lancet Gastroenterology and Hepatology in 2024, which was the first RCT on this question. The SPICY trial enrolled 139 patients and found that extended mesenteric resection was not superior to conventional resection for endoscopic recurrence. And there was also a signal toward higher anastomotic leak rates at 8% in the extended resection group versus 2% in the mesenteric sparing group. The Mesocolloid trial's interim analysis did suggest a benefit for an extended excision on endoscopic recurrence, but the COVID-19 pandemic led to missing endoscopic follow-up data in more than 20% of patients, which of course significantly complicates the interpretation of those results. And a key technical difference between the trials is the SPICY trial preserved the ileocolic vessels while the Mesocolloid trial did not. And that distinction also in how extended is defined may matter biologically.
Right. So here's our next case. We have a 45-year-old man with ileocolic Crohn's disease. He's presenting with his first resection after failing infliximab and another anti-TNF medication. He's a non-smoker, no previous surgeries. His pre-op CT showed marked mesenteric thickening, and his GI plans to restart a biologic post-op. But given the Mesocolloid and SPICY trials, would y'all perform an extended mesenteric excision in this patient? Does this significant mesenteric thickening on imaging change your decision? And kind of more broadly, are we moving toward oncologic type resections for Crohn's? And what are the risks with all of those things?
So my feeling on this is, there are some surgical principles you have to keep intact. Obviously, one of the things about the integrity of your anastomosis is perfusion. And, what are we sacrificing to keep pushing the envelope on what we don't know for sure is really, sort of a stimulus for a reactivation of Crohn's? Is this thickened mesentery and having residual mesentery there going to be what's going to do it? But I will tell you, the morbidity of having an anastomotic leak in this situation is real. Doing a high ligation, sort of a high mesenteric excision in this area, and then preservation of the colon perfusion is also something to take into consideration. Because when you start taking ileocolic high, and ileocecectomy is not exactly, a safe operation because the ascending colon is still requiring perfusion from the middle colic vessels. So you do have to be cognizant, and you end up having to take more colon as a result of a high ileocolic resection for this anastomosis. Right now, based on the data that we have, I don't know that I would chase extra mesentery at the sort of the consequence of increasing my anastomotic leak rate. I'm not sure that that's the right approach yet until I see more information to suggest otherwise.
Yeah, I agree with Dr. Trunzo. I do think there's something to be said for the mesenteric disease that we see in Crohn's. When you're trying to come across those mesentery with an energy device, it's sometimes just impossible. So, and, you can see when you physically looking at the bowel, that how this can be contributing to the pathology. But, short of taking out the diseased bowel that's associated with the mesentery, the mesentery that's associated with the diseased bowel, I certainly don't go chasing after the mesentery to do an extended at this point in time without more data. So I definitely agree with.
And for the trainees that are listening to this podcast, when you're dealing with that thickened ileomesentery or Crohn's related mesentery, using an energy device to take the mesentery is really a not a acceptable means to deal with it. These are things where you actually do have to, whether you're suture ligating or tying off, you actually have to control that mesentery much better. And those sealing devices, those bipolar energy devices, are not equipped to handle these thickened mesenteries to actually seal those vessels appropriately. And you will have post-operative bleeding. It's invariably will happen.
Yeah, I agree.
Yeah, I think, I agree that this kind of goes back to my point in the beginning that I adjust a lot of my management based on intraoperative patient specific factors. So I do think the mesentery, I do believe that has something to do with this disease process. So if I'm able to get it out, I do try to get as much as I can. That being said, if we've all encountered the Crohn's patients where the whole thing is the whole mesentery is like a sheet of concrete and it's super thick. And if you go trying to take that right next to taking the ileocolic right next to the SMA, you could potentially be in a world of hurt. So if that's bleeding, you're trying to control it, and then you get in the SMA, it would be a miserable, really devastating complication. So in that case, I think it's, that's more of a biologic disease process issue, and you're not going to fix the rest of the indurated mesentery throughout that patient by taking just a little bit more of the part you're resecting. So yes, I will try to get do an extended mesenteric excision in terms of get as much out of it as possible. But I'm very cognizant and wary of central thickening of the mesentery to taking it too high, because when that invariably bleeds, even after tying off, suture ligating, it'll still start bleeding through. Then you're trying to throw stitches and figure out, how do I get this to stop? You don't want to be close to the SMA having that, or the SMV having that problem. So to summarize, I'll try, but if I'm not, losing sleep if I'm unable to, based on the patient's intraoperative factors.
Yeah, and to piggyback really quickly off what Dr. Rosen is saying, even when you clamp and, cut and suture ligate those thickened mesentery, that sometimes can get a hematoma. So now imagine you have this hematoma that's expanding so close to like SMA. So just something else to bear in mind. Like I've seen a couple of expanding hematomas in these situations that makes me very uncomfortable.
Good point. Yeah, great discussion, guys. We only have a few more minutes left, so to bring it all together, we discuss, does the anastomosis type even matter? We talked about a more novel anastomosis and if that is more beneficial, the Kono-S anastomosis. And then we also talked about, is it less the anastomosis and more the mesentery? Should we be doing an extended mesenteric excision or not? And you guys all brought up some great points. And so how would you each summarize your current approach to ileocolic resection and anastomosis in your Crohn's patients?
Yeah, so I think the mesentery is definitely contributing to the disease. So I do try to resect what's safe to resect in when I'm doing my ileocolic resection. At this point in time, I'm still, like I said before, I'm gonna continue to do end-to-side until I see more data from Kono-S. And once I do, I'll make sure to get some pig intestines so I can learn how to do Kono-S properly. Or just go watch Dr. Rosen.
I'll send you a discount code for our local grocery store.
Sounds good. But yeah, that's, so that's my thought regarding the case.
I would summarize my thoughts as, for the anastomosis, I want to make it easy for my GI colleagues to be able to scope and monitor the TI. So I'm doing either a conal-S anastomosis or an end-to-side anastomosis as my two preference points. I'm trying to get out the mesentery as much as I can, because I do think that contributes to the disease process. But I think it's important to be versatile and adjust based on intraoperative factors. And again, I try to do either an endoileostomy or ileocolic anastomosis and avoid diverting loop ileostomies when possible.
And my final thoughts are, my go-to sort of anastomotic construction is going to be an end-to-side if I'm using a staple. If I think the tissue quality is not equipped for a stapled anastomosis, it's too thickened proximally from chronic obstruction and whatnot, and edema in the bowel. If I am going to do an anastomosis as opposed to bringing up an end, as Dr. Rosen mentioned, I have a similar sort of thought process on. I would do a hands-on isoperistaltic anastomosis, side-to-side isoperistaltic. That's sort of my preference. And as far as handling the mesentery, I do take extra mesentery, but I would not climb up the pedicles. At least I'm not ready for that jump until I see a reason to start doing that, to at least at this stage of the game. And but that's probably my final thoughts on my ileocolic resections. I believe that's going to end our discussion today. Thanks everyone for tuning in, and dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.